Hey guys, this is Gianfranco Froyo with First Aid. We're going to do the cardiovascular embryology section. This stuff is actually really high yield. They love to test you on the connections of pathology with embryological derivatives of structures, and it's really high yield and easy questions if you know the stuff, so let's go ahead and get to it. First part of the chapter is an intimidating table of cardiac structures and the embryological derivatives. Let's discuss the contents of the table individually. The first one isn't that bad at all. The arterial trunk, or the truncus arteriosus, will split into two. It will split into the pulmonary artery and the ascending aorta. Now next up, our book says that the bulbus cordus, here, forms the smooth parts of the left and the right ventricular outflow tracts. That's easy to visualize here because the central part of the bulbus cordus becomes very conical in shape, hence the name conus cordus. It will directly feed blood into the truncus arteriosus, and a cone is a very smooth structure. It will create very laminar flow, and we want that for it to flow out of the truncus arteriosus, which will split into the pulmonary and arterial trunks. It should make sense that this conically shaped conus cordus is going to form the smooth parts of the left and the right ventricular outflow tracts. While we still have this image up, let's talk about the next thing on your table, the primitive atrium. The primitive atrium will split and develop into the trabeculated part of the left and the right atrium. Now, what do we mean about trabeculations? Trabeculations are these large septations of columnar muscular tissue. Here we're talking about the trabeculations in the ventricle, but they also exist in the atrium. Now, the smooth parts of the atrium, you see that looks very smooth, are formed by structures that are going to be dumping blood into the atria. And this is the right horn of the sinus venosus and the primitive pulmonary vein. So also on this image, you can appreciate how the ventricle is going to swing around to become more anterior to the atrium, and the atrium will swing back towards the posterior side of the heart. This ventricle will split to form the trabeculated, not the smooth, parts of the left and right ventricles. Remember, the smooth part of the left and right ventricular outflow tracts are formed by the conus cordus, which is derived from the middle segment of the bulbus cordus. What about some of the venous embryology? This image represents the primitive veins in embryological development. To orient ourselves, let's remember that the sinus venosus becomes part of the right atrium. Its remnant is called the sinus venerum. The sinus venosus is where the superior vena cava will come in from above, and the inferior vena cava will come in from below. So sinus venosus literally means bag of veins, which is exactly what it looks like in this picture. Know how all of the veins converge to drain into this one bag, the sinus venosus. So the sinus venosus has two horns. Anatomically, this is the right and this is the left horn. The right horn of the sinus venosus becomes incorporated into the right atrium. It returns blood to the right side of the heart. After it has become part of the right atrium, again, we call it not sinus venosus, but sinus venerum. It is a remnant. Blood flow into the right atrium needs to be smooth and laminar, which is why the right horn becomes the smooth part of the right atrium, not the trabeculated part. Now what about the left horn? The left horn of the sinus venosus becomes the coronary sinus. This long structure here is the right anterior cardinal vein. It joins this other cardinal vein coming from above. When two cardinal veins come together, you form this here. This is a common cardinal vein, also called the duct of Cuvier because he was the first dude to discover common cardinal veins. So the combination of this right anterior cardinal vein plus the common cardinal vein will give you the superior vena cava. And this makes a lot of sense to us, right? Because the superior vena cava drains into the right side of the heart. The right horn of the sinus venosus becomes incorporated into the right atrium. Superior vena cava drains into the right atrium, and part of that right atrium is a remnant of the right horn of the sinus venosus. So notice how the structures from the superior vena cava return blood to the right horn of the sinus venosus. The right horn of the sinus venosus becomes the smooth part of the right atrium. And what dumps blood in the smooth part of the atrium in an adult? The superior vena cava. So let's move on to heart morphogenesis. And let's begin with the development of the heart. The heart begins as a simple tube. You can see this here. It is lined with endothelial cells and myoblasts. It is the first functional organ in the embryo when it starts beating in the 4th week. I remember this because we need blood for the rest of our organs to develop. So this is the first organ to develop at the 4th week, and we need it for the development of other organs. So the top part of the primary heart tube will bend down out of the screen towards us and to the right, while the inferior part will swing up into the screen posteriorly and up to the left. This is the cardiac looping that they talk about. Test examiners are not going to ask you which direction cardiac looping occurs. Rather, expect to see a CT image of the thorax like this, or a CT abdomen like this. None of us are radiologists, but from the CT scans, you should notice something. These organs are in the opposite location that you would expect. So in the CT thorax, notice how the heart is sitting towards the right side of the chest. We call this dextrocardia because dextro means right in Latin. In the abdominal CT, note how the spleen and the liver are switched. Normally the liver sits on the right side and the spleen sits on the left side. This is how test examiners are going to guide you to make a diagnosis of Cartaginer syndrome. Do you remember the pathophysiology? Cartaginer syndrome is due to a defect in the microtubule protein called left-to-right dynein. Without a properly functioning microtubule, cilia cannot function in cellular motility, fluid transport, and signal transduction pathways. This particular left-to-right dynein is called left-to-right because it is critical in determining the positions of organs either on the left side or the right side of the body. Without a properly functioning protein, guess what happens? We get situs inversus. So an important part of cardiac looping is knowing when things go wrong. So situs inversus in Latin is a term that literally means inverted sides. As you can see here, normal is A. It demonstrates that the lung has 3 lobes on the right side and the left lung only has 2 lobes, completely expected. The liver is under the right hemidiaphragm, compared with B, which is completely the opposite of what you would expect. The left lung has 3 lobes and the right lung only has 2. Note how the liver has switched sides and is now under the left hemidiaphragm. In addition, note how the spleen and the stomach have also switched sides. Everything is completely inverted. Again, this is due to a defect in left-to-right dynein. You need to be ready to see this in the form of a CT scan and then be able to make a connection or reference to the biochemistry section. Now let's keep rolling to another high-yield part of the book.
The names of the structures involved in the development of the atria will guide your understanding of what initially seems to be a rather confusing sequence of events. But let's use this helpful diagram and we'll power through it. Now, first of all, a segment of tissue begins to grow from the top of the atria, and this first segment of tissue, or septum, is called the septum primum, for the first one to show up. It begins to grow downwards towards the endocardial cushion that's sitting here in the atrioventricular canal. Now pause for a second and check out how the septum primum has now created a smaller communication between the left atria and the right atria. We call this small communication the ostium primum, or the first small hole. Foramen and ostium both mean hole, so don't let the interchange between the words throw you off, or the flow of understanding. So ostium primum and foramen primum both refer to the first hole created by the descent of the septum primum. Now eventually the septum primum reaches this endocardial cushion and it starts to fuse. This is a problem because we want to maintain the communication between the left atria and the right atria in the fetal heart. Immediately after the septum primum fuses with the endocardial cushion in the atrioventricular canal, two other things start happening. Areas here in the superior part of the septum primum start to degenerate to create a new hole. And a second septum, the septum secundum, begins to descend from the right side of the septum primum, and it also starts to descend towards the endocardial cushion in the AV canal. What is this new hole formed here? Remember, it is the second hole or the second foramen that we have mentioned that permits communication between the right and left atria. This new hole is the foramen secundum, or sometimes called ostium secundum if you're really old Latin and classic. Unlike the septum primum, the septum secundum does not grow all the way down. Now notice here in this third image that the septum secundum is hanging to the right of the septum primum. Now the way the septum secundum sits over the foramen secundum makes the foramen secundum kind of now look oval in shape, which is why they named the foramen secundum the foramen ovale after the septum secundum has fully developed. Let's quickly review this stuff because you probably already zoned out and you have to really know this and you just have to see it more than once. Here's the septum primum growing downwards towards the endocardial cushion that's sitting in the atrioventricular canal. Note how we have the foramen or ostium primum now forming. In the second image, the septum primum has fused with the endocardial cushion, and an area of apoptosis in the superior part of the septum primum forms this new communication, which we call the ostium secundum. Now the septum secundum will grow to the right of the ostium secundum to help form a unidirectional valve. So why does all of this happen? To create a pressure valve. The remnant of the septum primum here will act as a unidirectional pressure valve covering the foramen ovale to prevent blood from flowing from the left atria into the right atria. Remember, that's bad. We don't want that. Any increase in pressure in the left atrium will push the valve shut and prevent any desired flow. So that way, these two will be touching and no flow will occur from left to right. There is no problem with flow from right to left though. That's because we want oxygenated blood that's coming from the mother to the fetal heart to bypass the pulmonary circulation by going straight into the left atria through the foramen ovale. So what happens after birth? Well, after birth, the pulmonary circulation vasodilates and the pressures on the right side of the heart will drop dramatically. So now the left side of the heart will constantly have pressures that are higher than the right side. What is this going to do? Well, it'll push the septum primum this way permanently up against the septum secundum. Eventually the surfaces will fibrose together and this obliterates the potential for any abnormal communication. Now the small depression that's seen after the fibrotic fusion is a remnant of the foramen ovale called the fossa ovalis. So what happens if this fusion does not occur and you do not get a fossa ovalis?
So if the fusion of this septum primum and the septum secundum does not occur, we do not get a fossa ovalis. Instead, we have a patent foramen ovale. This is now an abnormal communication after birth between the right and the left atrium. It will allow deoxygenated blood from the venous circulation to bypass the right ventricular and pulmonary circulation and go straight into the left atrium. So how are you going to be tested on this? Like this. So a 22-year-old male with factor V Leiden presents after returning from his around-the-world vacation with new onset hemiparesis of his left side. After performing a complete neurological workup, you confirm he has suffered an ischemic stroke. What is the most likely etiology of this patient's disease process? This question is kind of a stretch, but it is testing your ability to combine your knowledge of a coagulopathy in factor V Leiden and cardiac embryology. This patient just finished a long flight around the world, which should make you think about leg stasis and Virchow's triad. So when you combine stasis with a coagulopathy like factor V Leiden, this should make you think about a DVT. The fact that he's suffering from neurological symptoms means that somehow this embolus crossed over from the venous or right side of the circulation into the left side of the circulation. and finally went up and lodged into one of the arteries of his brain and caused this left-sided hemiparesis. Now, where would the embolus go if it did not cross over because this person does not have a patent foramen ovale? Let's say it is a perfectly healthy patient. It would get trapped into one of the smaller branches of the pulmonary artery, creating a red or hemorrhagic infarct, like this one. Red infarcts occur in organs with two types of circulation, such as the lungs, the liver, the brain. Remember, the lungs receive pulmonary and bronchial arterial blood. Even though a paradoxical embolus is a clinically rare scenario, examiners love testing this kind of concept to incorporate some embryology, such as a patent foramen ovale, and a much more common clinical pathology, such as a DVT. So again, you should be thinking this patient has an abnormal communication between his right and left atria, or right and left ventricles, such as a patent foramen ovale, ASD, VSD. The patient in the vignette we discussed suffered a paradoxical embolus. It is called paradoxical because you would not expect a clot that formed on the right side to cause symptoms from the arterial circulation or left side of the heart.
Now, the two developing ventricles have medial muscular walls that are growing towards the midline. Eventually, the left and right will meet in the middle, right here, where the future interventricular septum will originate. Now, when the medial aspects of the growing muscle meet at this midline, the growing muscle has nowhere to go except up into the chamber. Again, this is how we make the muscular interventricular septum. So again, we've made our muscular interventricular septum by the growth of the muscular part of the walls. Notice how we still have a communication above this newly formed muscular interventricular septum. Now what's left over is the interventricular foramen. How are we going to close off this communication between the left and the right ventricle? The endocardial cushion sitting directly above the muscular interventricular septum will send a membranous sheet of tissue downward. Now this is the membranous interventricular septum. Yes, that's right, folks. The interventricular septum has a muscular and also a membranous ME septum. That means that there are two types of potential ventricular septal defects that occur, muscular or membranous. The most common by far is membranous because it is derived from endocardial cushions. I just remember that muscle is stronger than a thin membrane, so it is more common for holes to occur within the membranous interventricular septum. Now, what kind of shunt would this defect create? At birth, you would have a left to right shunt across this ventricular septal defect. So we've knocked out the atria and ventricles. Let's talk about the outflow tract.
Excellent, guys. Let's keep going. On to a flash quiz for us. The blank forms to close the interventricular foramen and separate the two ventricles. The membranous interventricular septum. We know this very well, that the inferior part of the ventricle will grow up and form a muscular septum, followed by a projection of the membranous septum from the inferior endocardial cushion. The muscular will meet the membranous to close off the communication between the right and the left ventricles. Failure to do so is most commonly due to a defect in the membranous part of the interventricular septum.